for health promotion, disease self-management, things like that. I just want to briefly go over what we know, where we are in the field, and thinking about where we can advance the field as a way to kind of set the stage for the types of research that I would encourage you to pursue, and then go more specifically into the priorities for trials, for their design, implementation, and scale. So first of all, you know, I want to just start with my own definition. And when I say mHealth, I think broadly about the use of mobile or digital solutions to facilitate healthy behaviors, so for individuals, but also to support the delivery of care in clinical settings. So it's not just things targeted at the end user, it's not just apps, it's a number of different solutions that address a problem for access. And they can be delivered on the internet, they can be delivered through social media, through text messaging. I overheard a brief conversation here about Twitter just a minute ago, so that's not up here, but it's a form of social media. Definitely apps, we're seeing more of those. We're starting to see more applications related to artificial intelligence and virtual reality. Certainly machine learning is becoming more considered in the field, and then sensors. So what have we learned from mHealth research? Well, if I had been giving this talk even as recently as 5 or 6 years ago, I would have continued my usual complaint that we didn't have a lot of evidence for the efficacy of these tools to impact behaviors and health outcomes. But I think now we're finally starting to see a shift, and we're starting to see a growing number of studies that do support the impact that mobile and digital solutions can have on things like the antecedents of health behavior, things in social science that we consider like norms, self-efficacy, attitudes, knowledge, social support, those kinds of things. We're seeing evidence that these tools and these solutions can impact health behaviors. So we have evidence that they can impact smoking behaviors, physical activity, fruit and vegetable consumption, condom use, sexual abstinence, medication adherence, those types of healthy behaviors. And then now we're also starting to see evidence that they can impact health outcomes, things like reduced blood pressure, HbA1c, depressive symptoms, and weight. So we are seeing a growing number of studies that have been done in this area. So here's just some examples. You may be familiar with some of these. Mood Gym is an application that you can use to address mood. There's a number of text message programs as well as apps that are out there related to smoking cessation. This is
when I'm done with this webinar,
for
I'm going
diabetes self-management.
and I have an appointment like 2:30, so I may not see you the rest of the day.
Text for Baby is a program that actually was developed
Thank you. Good luck. Hope she shows.
And so it's gone a different direction than we would typically endorse. But some of the evaluations of Text for Baby have looked at things like postpartum physical activity and shown that the program can be effective. There's also several that are apps as well as internet-based programs for physical activity and nutrition. Some of our own work using Facebook and other social media outlets for HIV prevention, specifically condom use. And then another example of our work is shows how it's just one example of how we're starting to see things also in the global south. This was a project we did in Uganda using the internet for also for HIV prevention with secondary school students. So all of these and more are examples of programs that have some efficacy for behavior change or health outcomes. So that's kind of where we are, but what is missing now in mobile and digital health? So one of the big things that we're understanding is that we don't know how our effects are realized. So actually in face-to-face programs, we don't really know that either. So the advantage we have here is that we're starting to have access to the data from our systems to be able to explore this more and be able to do it in a way that helps us understand. So typically what we'll do is we'll study an intervention, we'll see if the intervention has evidence of changing a behavior or a health outcome. And then we say that that intervention can get that effect that you're interested in. But we're not quite sure. Is it one part of the intervention? Is it a particular element in the intervention? Is it a certain number of times that you have to engage with the intervention? So we don't know that yet. So similarly, we don't know the right mix of exposure and engagement. So if somebody interacts with your mobile or digital health solution 20 times, is that enough? Or do they have to interact 300 times? And then when do they have to interact? And is there an optimal time of day, day of the week, particular time of month, that kind of thing. We haven't reached highly marginalized groups. And this is, you know, we're in the School of Public Health. Our lab focuses on health disparities and health inequities. And so this has really always been a challenge for us, but we want to make sure that now we've got good evidence that populations around the world are using digital and mobile tools in their day-to-day life, and we haven't taken advantage of them to realize our programs with those groups. And then we seldom replicate or scale our work. And again, like the very first point, knowing how the outcomes are realized, this is not unique to both mobile and digital health. We have this problem in our face-to-face interventions as well. Okay, so I was giving a talk last week in Champaign-Urbana to a bunch of folks who are in health communication and who teach presentation skills. And so I know this violates everything that you've ever known, but in that audience I showed this slide and I thought, oh my gosh, you know, really, this is a no-no. So I'm not intending for anybody to read anything on this slide. All I want to do is point out, this is really a summary slide of all of our, and some people will recognize this because they had a class with me and I made them fill this out. But what it is on this side are the types of things we look at when we're evaluating the evidence, right? So things like evidence of efficacy for the effects on the antecedents of behavior change, health outcomes, sustained effects for a long time, beyond 3 months typically, whether a high-risk audience has been included, whether there's been research syntheses or meta-analyses. What I want to point out here is that at the bottom, this is where we're looking at the replication of studies and the dissemination of studies. And then across the top are the different modalities. So the internet, text messaging, social media apps, games, sensors and trackers, and then AI and VR, artificial intelligence and virtual reality. And you'll see that in general, there's this big gap down here where we don't have studies published that address replication or dissemination. So that illustrates that gap. And then over here, as you get to the more recent types of modalities that are being used, you also see quite a few gaps. And then you also, the red is when we've seen some negative effects. And so for example, this one, a sensor was developed to track high blood pressure. Yeah. Oh, I'm sorry. So, oh, I don't have a little, oh, I do have a little laser. There we go. So the red is for things that are negative effects. So there was an app developed that was supposed to monitor blood pressure, and it was doing it incorrectly. So the problem there was then it would alert someone that they had high blood pressure, or it wouldn't alert them if they did, right? And so then there was a big problem. There's potential for a big problem around medication misuse. And then on the bottom rows, just down here, I'm not sure if this pointer is working either, but you can see the bottom 3 rows are largely blank, and that's around replication. The other thing to point out here is that just because these are filled doesn't mean that we've covered the waterfront in terms of all of the types of things that you could look at. It's just that we have some examples. So these are largely around things like smoking, physical activity, nutrition. We don't have as much that's been done in areas like mental health. I'm working with Jenny on working with older populations, for example. That's less common. I talked with someone last week, and we're working on programs that are looking at more rare diseases. So just because these are filled in doesn't mean that we've got good evidence for everything. It just means that there is evidence for some type of behavior change or health outcome. Okay, but still, we don't know how these outcomes are realized. I would advocate for the use of theoretical frameworks more consistently. We don't know the right mixture of exposure and engagement. So we need to explore dose response, or as my colleague Beth suggested, this is an overly medicalized term. We need to evaluate exposure and how much exposure is needed. And then we need to consider access and who's accessing our work. And then we need to replicate and scale our work. So the point about replication is really key for mobile and digital health in particular, because you look at these programs and you wouldn't necessarily expect that the effect size of participating in an intervention is going to be the same for a mobile solution. It might arguably be less, because someone is not going to spend the particular amount of intensity or time that they might with an in-person smoking cessation program, for example. So you could expect that for the most part, excuse me, that you would have smaller effects than traditional face-to-face programs. So in order for us to have the impact that we could anticipate for mobile health, we have to reach more people. So if you have smaller effects, but you reach larger numbers of people, you could have greater population impact, but you have to do it. You have to replicate that, and you do have to disseminate. So utilizing theoretical frameworks more consistently. So here, this is a theory that we developed called the integrated theory of mHealth. And the main point here is that on the right, these are things, this isn't necessarily a static model, but the right represents the types of things that we will often attempt to intervene on for health behavior interventions. We often look at interventions that facilitate self-efficacy or increase social norms or social support, and think that those types of things lead to a behavioral outcome or a biomedical outcome. And this is well supported in the literature. But what I'm suggesting is that in the mobile and digital health environment, it's not identical to a face-to-face environment, and there are additional things to consider. And one of those is the idea of access. And this goes back to trying to get more marginalized groups having access to our programs. But it also is a question of simply designing the right thing for what it is you want to do. And I think what happens for us is oftentimes in society, we'll get seduced by the sexiest new bell and whistle or new application, when in reality, that may not be the appropriate strategy to use. So if you're thinking about ways that you can increase access to your programs, I'm going to suggest that we have certain trial priorities. So the type of research here it's definitely not more of, we do have a lot of the types of small qualitative pilots where you bring people together and they say, yeah, I'd use that. Yeah, it looks exciting. That's not enough. We need now a multiple iterative kind of understanding of what people will use and what makes them come back to using it. Mainly, we're getting this because we know that, particularly with mobile health apps, there's literally tens of thousands. There's now over 150,000 apps out there that are related to mobile and digital health in some way. So, you know, yoga or mindfulness or physical activity, etc. But the median number of times those are opened after they've been downloaded is once. So people aren't aren't, and then fewer than 1% of them are actually downloaded. So people aren't really using these tools in the way that we would hope. So I'm going to suggest that one approach is to use N of 1 studies. And this was something that Dr. Glasgow and Dr. Riley at NIH suggested many years ago with an attempt to look at more rapid designs for doing our work. And so think of this as multiple within subject studies. So, you know, when you go to the eye doctor, well, for those of you who wear glasses, you go to the eye doctor and they say, which is better, A or B? And you say B. Which is better, B or C? You say B. Which is better, B or D, right? So think of it the same kind of thing. You want to put your material in front of a small number of people and get that person to look at version A or B. Now, which is better, B or C? Which is better, C or B, right? And so it gives you multiple rapid iterative types of testing with a single individual. And you can have smaller samples because you can pretty quickly come to saturation or convergence. So it facilitates opportunities for things like personalized design, improves opportunities to reach those who haven't been reached. So you can really be very selective about who you want to be reaching. Is this the right content for you? And it can be around content for sure, but it should also be around what is the platform that I should use? Should I be using text message? Should I be using an app? Should I be using virtual reality, for example? And all of those things are really important. If you're living in a rural area and you don't have good access to wireless, and you'd have to drive a long distance to come in and use a virtual reality platform, well, then maybe that's not the one you want to go with, right? It can also facilitate engagement with content. I'm going to come back to that, but the idea here is really understanding which message and the way a message is framed is better overall. The other thing is the idea of using technology to implement both new and more traditional formative approaches. So here's where you can think of the idea of using machine learning, for example. So now I'm not sure if people here have heard about innovations using Twitter. So you can scrape Twitter feeds and look at them in geographic areas and search for particular keywords, and that will give you information about, for example, emergent flu. So if you've got information that says, you know, there's a lot of people tweeting about fever and cold and chills, and it's happening in December and it's happening in these geographic areas, that's a form of, you know, a quick assessment about where you can go to promote flu vaccine, right? You can narrow your target kind of marketing. So machine learning is a new tool that we have, and it's a way to facilitate some of your formative work as well. And then we've been experimenting with asynchronous online focus group discussions as a way to gather data more quickly and really understand how we can get diverse perspectives from people in multiple settings in a way that's convenient for them. And some of the research on this approach has showed that it's equal in quality to doing in-person focus group sessions. There's some advantages in that you don't have to transcribe, you can just download it. There may be some disadvantages because you don't necessarily have the opportunity to probe while the conversation is going on. So another trial priority around access and improving access is one that's focused on beta testing, but I would say here on the theoretical perspective, it's important to bring in perspectives from computer science. And the PacMed model, the people at the Center for Mobile Application Design, is one that we like to use because it really gets into improving the user experience and the user interface. So that at the end of the day, the last thing that you want is to have fabulous content that nobody can access because it's frustrating or error prone or difficult to navigate, right? So you can before you even get to, do you like the content? Will you engage with the content? You want to get to, is this tool working? Can I log in? Can I input data? Can I get data out of the system? Can I get through the system in a way that I'm supposed to? Is it appealing? And can I figure out how to come back and do that all again the next time without having to figure it out again, right? Because this is like me using SAS. It's every 6 months or something, I'll have to code something and I'll be like, okay, now what was it? And so I usually just give up and call one of our superb analysts, right? So that's this idea of access. Now I want to talk about engagement. So this is the other area that I think is ripe for investigation within mobile and digital health. And it's really to answer the question of the right mix of exposure and engagement to realize effects. And like I said before, this is not something that is unique or a deficit only for mobile and digital health. This is something that we don't always or don't frequently do in our traditional interventions either. So here, certainly the study of engagement, you have the opportunity to download all of the data from the systems that we have. Now, we haven't had that necessarily before. How many times people are opening your tool, how many times they're engaging with the content, how long do they spend doing so. That's all useful, and you can get it from within your systems, and making sure that you get that so that you can study it is important. But then there's also these other platforms that are really very readily accessible, and they include things like your data analytics platforms from Google to understand what people are engaging in. And if you've ever gone on there, you'll see they have a pretty robust set of data points that you can look at in terms of what people are engaging with, where, when, and for how long. And then questions about what are people sharing. That may or may not be relevant, but it can be helpful to understand and investigate. You know, if I like it, does that mean that I'll share it with someone? And if I share it with someone, do I have a large enough social network to be influential? And then asking the questions about, is there an exposure response instead of dose response relationship between engagement with content and the behavioral or biomedical outcomes? You would think that maybe there is. You know, you have to have a minimum of engagement 3 times in order to get a benefit. But maybe there's a threshold where you're not getting any additional engagement, and that might be important too. So there's a good book that I would recommend that talks about this in some more detail, and it's from a marketing professor actually, and he created this acronym STEPS, and it was based on research that he had done looking at what makes things go viral in the social media space. And he said that there's these elements, they don't all have to be present, and you can have a mix of some or maybe just one of them in your content in your mobile platforms. And status is really, I'll share the message or I'll share the content if it makes me look good. Does it make me look funny or wise or, you know, particularly knowledgeable? I'll share it if it's a trigger, it makes you do something. A good thing here is, a good example here is just an alarm on your phone. You know, is that something that you would tell somebody in your social network to use to, for example, remember to take a pill? I'll share it if it evokes an emotion. And you see this on social media all the time. You know, people will share things that make them angry or make them excited or happy or laugh. I'll share it if it's a brand, if it's public. The idea of public is that it's your brand or it's the program that you want to promote. And here I think within public health or medicine in general, we have a real advantage, because if you have a brand that you're associated with, your clinic or your credibility as a professor or as a researcher or as a lab, that's compelling for your audience. And then if practical value, if it offers practical value, this is kind of like a self-efficacy concept. If it gives you specific steps for building skills, people are likely to share it. And then one very common thing, we see this in health communication theory a lot, if people can tell a story, have a narrative, they're more likely to share it. So those are things to think about when you're looking at your design, but those are things that you could explore in engagement and exposure type of research. So we can understand, okay, so did I have, more messages that were narratives, and does my audience like that more often? And so that could help us understand what gets people to look at our stuff and what keeps people coming back. Definitely reaching marginalized groups and back to access is this idea of scaling and replicating our work. And once again, it's not something that's unique to mobile and digital health, but it's critical to do. And I'll call out Dr. Glasgow again. He's been talking about this for a long time, and not just with mobile and not just for digital and mobile solutions, but also for our face-to-face interventions. And we need to study dissemination and implementation, consider those types of pragmatic trials that help us understand what are the attributes of mobile and digital health systems that appeal not just to the end user, but to people like system administrators, people who are in a position to make decisions about adopting and using this throughout their institution, school leadership, for example, and then understand what will facilitate adoption, implementation of your system, and maintenance over time. So those are critical. Also, we're starting to see that people are putting attention to studying the economic benefit to establish cost effectiveness of using mobile and digital solutions as well. So this is a summary, my last slide. So for designs and trials, I would advocate that you carefully consider design solutions through rigorous formative work that go to things like N of 1 trials, utilize machine learning. You can do online asynchronous focus group discussions. Consider access, so make sure that you're developing something that your audience actually uses. Don't insist on virtual reality because you love it, but because you know that your audience will love it too, and they have access to it. Make sure you beta test your solutions so that you understand that your effects or the impacts that you're seeing are because of your program, and not that you're not seeing because they're stuck in some error in the system. And then consider engagement. So dose response analyses or exposure analyses with mediational modeling to establish pathways to efficacy. And then definitely consider how to disseminate and scale. Who should be adopting these? How can we get them in front of the largest number of people as possible? And what is the return on investment through economic analysis? That's all I have. I think we have time for some questions. Yes. Mm-hmm.
How feasible, I guess, is it for these research-based health solutions to the private sector? You mentioned something about it, or this, maybe develop it first, but then start evaluating.
Right.
How feasible, I guess, is it for researchers to keep up with people?
Yeah, it's a huge problem, and I harp on this a lot. I mean, and I think some of Russ's work showed this too. The timeline that we have to ask and answer our questions, to ask them, get funded, get rejected, then get funded, and then do the trial, and then publish the results, is an eon in the industry. So I think what we need to have are systems in place so that we could do this more rapidly, for sure. So we need to try and shorten the timeline, and we're doing a couple of things in our lab. One is we have a standard number of trial designs. I mean, there's not a whole bunch of complexity here. A lot of times you're doing some simple 2-arm randomized trials. And so we've gotten to a point where the IRB knows what to expect from us. And so we can shorten that timeline with the IRB because they recognize what we're doing. It's typically not very invasive. So you can shorten that timeline. We're also trying to build a registry of people who are ready and available to do, to trial and participate in research. So that can reduce the recruitment timeline. You know, it still doesn't address anything about how long it takes you to get funded. So I think in there, we've had several experiences where we've gotten funded, particularly by NIH, and by the time we start the trial, it's already obsolete. So we got funded to do something on the internet, and as soon as we got the trial underway, MySpace came out, and it was the very first social media platforms. And by the time we published, it was too late. You know, it had already become obsolete. The next time it happened, funded again by NIH, we proposed to do something on MySpace, and then Facebook took off. So, you know, I was just pulling my hair out. But at that time, I just said, okay, look, I'm going to the project officer and changing. And you can do that. You know, you can ask them for consideration about changing your design. So I think, or your some of the aspects of your trial. So I would encourage people to not be afraid to do that because that's critical. But that still doesn't get over some of the real challenges that we have in keeping pace with industry. So I think paying attention to really trying to develop some of the foundational information. What is the type of message that consistently engages people? And then applying that to the new program. What is the type of method that helps get us access to marginalized groups, and applying that as well? So those are just some ideas. I don't think we're gonna quite be there because we always argue with industry over, they wanna commercialize their stuff and we wanna have an impact with our stuff. So we're trying to figure out how to have a meeting of the minds there, and it's not always easy. Yeah. So we're working on a couple of SBIRs, and I think that is a useful mechanism. Within the university, it's a little bit easier to do the STTR rather than the SBIR, because with the SBIR, you have to have everything outside. But yeah, that's a good suggestion. Yes?
Just to kind of follow up on an issue about maybe the goals within the school.
Mm-hmm.
You're reaching highly marginalized population. I think that there, there's a real opportunity in the future to bring alongside the industry to realize what we're doing and appreciate the value of plastic, particularly with your focus on replication.
Mm-hmm.
Evidence-based. One of my current soapboxes is evidence on what? And that evidence, a lot of evidence, as you say, from small efficacy studies on one outcome, but we don't have on reach, which you get, but on adoption of all settings, sustainability, and then I really like, I think it might be fun to, you have time today, talk about it, about cost, and how to do that, whose cost, at what time, ROI from whose perspective. And then also this critical issue isn't, and I think it's close to a crisis here, but everywhere else too, a failure to replicate.
Mm-hmm.
And I just think that's really important issue, and maybe something with your focus in your lab that could be.
Yeah. So I think you asked me 6 things. I'm never going to remember all this. So I'll try and go backwards. So the replication, I think, is critical. So I talked about scale and dissemination, but I think we should be spending time on replication first. Because even with those that, you know, horrible slide with the stuff you couldn't read, those are all single trials. There's some meta-analyses in there that are good, but we're not seeing replication of specific trials. So we need to see more of those for sure. I think this idea of how do we partner with industry and think about cost, it feels to me like you know, we need to be looking at systems like hospital systems or clinic systems, or groups that serve community organizations, or perhaps Medicaid or WIC, you know, things that have access to large numbers of populations, and be working with those administrators and talking about things like return on investment and the cost. And I think people get very nervous because those folks say, well, are you trying to replace us with your app? And we didn't talk about that at all, really, but I would advocate, no, we should be using these to enhance or supplement or extend, because people tend to trust, or they develop a trusting relationship with their physician, for example, and they want to have the kinds of things that we can do with a text message or an app that someone can access that gives them more information about their clinic, and it's credible. So that's that brand idea again. So I think we can be working with program and system administrators more to think about the value of this to enhance the types of things that they want to do and save them costs. And those are the only questions I can remember that you asked. Okay. Yes. Uh-huh. Yeah. Yeah. Hardly at all. I mean, so it's interesting. We started the lab 3.5 years ago to try to do just that, be more of an interface with industry. And because we have these differing goals, because they're interested in commercializing a product, they're not really spending a lot of time on that access question, on reaching marginalized groups, on understanding what they'll use. They would like to put it in the App Store and sell a lot of it. Now, that's not universal. There's a lot of people out there that aren't doing that. And if there are any developers in the audience, I would say they probably aren't that type if they're at this talk, right? But I think just by and large, that's a challenge for us. So what we kind of have pivoted, and now, and this is actually one of the online questions, what we're trying to do now, and most of who we've partnered with in the past 3 years are clinicians who have a great idea or who have already developed something themselves, right? And created an opportunity for use in their clinic or in their community organization. And they've come to us to say, we need your help in evaluating it. And that's what our intent is now. We think that that's potentially a better way to go because, well, it's because industry isn't coming to us. We have to kind of rethink how to get them to the table. But also because, you know, really the clinician or administrator perspective, you're the ones who, you know what the challenges are that your patients or your clients face. And so from their perspective, you can talk with them and think of something that we can work together to develop. So that's one thing. So we're available for that kind of thing. If people have an idea that they want to see to fruition, we can consult with you and we can work with you to think about how to set those up. And that was a question online. But as far as getting industry back to the table, I'm thinking that it's only going to be harder for companies to differentiate themselves with this just very crowded market. So with more than 100,000 apps out there, why is yours different? And I think the only way that you're going to be able to is that providers aren't going to endorse it and have their patients use it unless there's clinical evidence of efficacy. So those are some of the areas where we can have a little bit of leverage. but it continues to be a big challenge, I think, and it may only get worse as we get a more rapid development of innovations. Mm-hmm.
The broad idea was going to be that basically Under Armour sent an email to all the users, and basically allow them to opt into theirs, all that sort of stuff. And everybody was on board, it was moving swimmingly until we got to the issue of implementation, and the university put the brakes on it completely, and that project just totally stalled out. We worked on it for 2.5 years. And now
Right.
so that's another challenge.
Yeah.
Sometimes who owns the data, who's protecting the data. There's also provisions around that.
Yeah, that's a good point. We have to work those contracts out, and we haven't figured it out. Mm-hmm. Mm. Mm-hmm. Mm. Mm-hmm. Yeah, there are a number, especially with SBIRT, that are out there. I've seen trials of those being used in emergency room departments or in emergency departments, and then in some substance use treatment facilities. So I think there's some real advantages at the clinical level. There's another one that's been developed, and this is an example of a really great partnership with a developer and our faculty. It's the Heart Smart Kids program, and it's being developed with some faculty in the College of Nursing, and that's similar. It's an assessment that parents do in the waiting room while they're waiting for their well child visit, and the data then get transferred to the physician, who then gives them some feedback that's targeted and specific to them based on their responses. Where there's growing examples of being able to link some of those data to the EMR, which is a critical issue. However, we're seeing some, and some of the folks that I'm working with here have raised some concern about, well, what data are we linking to the EMR? I don't want to be inundated. I don't want to be overwhelmed. So we have to be careful about what's getting linked, as well as, of course, the security issues there. But there are great examples. We've done work actually more outside the US with using digital platforms for collecting data for surveillance, but then also in absence of an electronic medical record. And by and large, clinicians love it because they have an access to a system that helps them do their job more efficiently. Yeah, David.
Yeah, that was a terrific overview of the field and very helpful to see your conceptual framework and sort of where research might be needed. I have two questions. First, do you have an example of a successful interaction with industry? I was wondering what that looked like and what made it work. And second, I'm wondering where the research funding is for some of these questions. Because, I guess particularly for some of the formative developmental work, it's just so hard to get funding for that. There's no federal funding for it, for sure. And even, our own institution, I've been mentor of a number of projects that, because they're formative, we're supposed to be funding that, but we're not. And,
yeah.
Even our CCTSI is always looking for significance and innovation. They're funding things that aren't formative.
Yeah. So for the first question about are there examples of success, we're working with a group called Mobile Applications for Community Health, and they've developed a smoking cessation platform. And we help them with that formative work. We use some online asynchronous focus group discussions for the development. And now we're in the phase of working with them to do some beta testing. They came to us largely because the head of that company was a student in the School of Public Health, you know, so she was like, oh yeah, she drank our Kool-Aid. So we have we have you know, some of those from our own outreach, and I think we could probably do a better job of trying to, I guess, broadcast and market the services that we can provide and the benefit, right? This is in an increasingly crowded environment. You have to differentiate your product, and no one who could, you know, disseminate it widely throughout a system is going to endorse it without evidence. So I think we have to do more of that. And then, sorry, your second question. Oh yeah, so funding the formative work. Yeah, you know, that's not typically some of the stuff that the that your R01 type of work. I think SBIR is a good one for or STTR is a good one for some of that formative work. You can get the fast track, is it called, or the, somebody help me on it. It's the combined. Oh, we have a class at 1. Okay, okay. So I think SBIR is a good mechanism. We're trying to get the CU Innovations to recognize some of this challenge, get people to be able to develop and pilot something so that then they're in a good position to go for an R01. So that front formative work is good. I'll let Russ answer the question about the replication. Who's going to pay for that? Right. Yes.
Well, thank you everybody for coming today. We hope you enjoyed your lunch if you were here in person, and I hope you enjoyed your lunch even if you were not here. But thank you. We in 1 month we'll have another presentation. And who's our speaker next time?
For those of you who are asking questions about industry and partnering with industry, I think you'll be very interested in next month's presentation when we have Gabriel Camargo, the CEO of Ingenious Softworks, will be here with us to speak to how to do successful partnerships with industry. Thanks for coming. We look forward to seeing you next month.